trying to search which is the button to be pressed. Okay.
Sir.
Can I go ahead?
Yeah, please go ahead, Shiva.
Yeah. The point that we are going to discuss today will be the problem of large ducts. The problem starts with what is the definition, how to identify, how to diagnose it on echocardiogram and angiogram, what is the hemodynamics of a large PDA and decision on operability of large PDA, and then interventional problems. And towards the last part, atypical ducts or atypical situations. What are the problems in defining a large PDA? What is a large PDA and what is a moderate sized PDA? Unlike ventricular septal defects where there is a definition to link the aortic size to the PDA, which makes logic, PDA does not have such a definition. Size of the duct varies from aortic end to pulmonary end. And even if we take the narrowest portion, the length of the duct adds to the resistance and alters the shunt. For precise measurement, ideal view is always chosen. What is an ideal view? This is the chest. The normal parasternal view we do in this plane, but we know that the ductus is in a different plane. So the ductus needs to be left parasagittal. And suppose if you are having the left parasagittal cut through the ductus, how it is going to look on the echocardiogram? The echo probe is going to be on the left parasagittal area. And it is going to start from the right ventricular outflow tract to the pulmonary valve to the main pulmonary artery. And this is going to be the ductus. And how this image is going to be transmitted on echo screen. Echo screen is going to invert it 90 degrees and show the right ventricular outflow tract, pulmonary valve, main pulmonary artery, and this ductus. And this is what we are going to be visualizing, a ductus, and this is going to be the landmark for measuring a PDA to call what is the large PDA. Same way, aortic end can be seen from the same way the PDA can be seen from suprasternal view also, not in the conventional suprasternal long axis view, but we need to realize that PDA will come more sagittally. So we need to keep on the leftward side of the suprasternal notch and make the probe almost sagittal to the plane of the body. Only ideal views will measure correctly, and then only a large PDA and its dimension can be diagnosed accurately. Definition of a large PDA. Basically what we mean is anatomically large looking ducts. As I mentioned earlier, we cannot compare with another structure, but with near systemic pulmonary artery pressures. No size definitions. A preterm with 3 mm PDA is very large. In an adult, a 2 cm PDA is very large. What is the correlate? The pulmonary artery pressure more than 50 to 75% is going to possibly tell that that PDA is large. However, there is a caveat. Only when we do an invasive imaging, we can get this picture and identify what is the pulmonary artery pressure. And prior to that, what we have is only an echocardiography. Look at this echocardiographic Doppler screen. The screen is showing a peak velocity of 3 meters per second, which will give 36 millimeters of mercury. However, that PDA is extremely large. So what actually happens? Whenever there is a large PDA, there is something called impulse gradient. The kinetic energy of the blood flow, the velocity is converted into gradients by the echo Doppler principle, and Doppler gives a high velocity. Impulse gradient is also seen in mitral valve in a large PDA. You get a sort of mitral stenosis. You have an aortic stenosis because of aortic valve gradient. All these are impulse gradients. What is the problem in clinical identification and clinical diagnosis of a large PDA? Clinical signs may become subtle. Clinical signs of PDA is highly dependent on low PVR. If there is higher PVR in a large PDA, clinical signs become subtle. I have seen this often whenever the PDAs are extremely massive, as in Himalayan countries like Nepal, or in African countries at high altitude as in Ethiopia, Rwanda, or Burundi, where PDAs measure 2 to 3 centimeters, problems in echocardiographic diagnosis of a large PDA. The morphology of the PDA is highly variable. It is not standardized. You can have a PDA which is long and tubular. You can have another PDA which is completely a window. The descending aorta to the main pulmonary artery, there is no ampulla at all. So conventionally, long ago, Kirchenko, Lee Benson, Bob Freedom from SickKids Canada gave a definition, gave a classification. Large aortic end is type A, narrow aortic end is type B, tubular is type C, multiple constrictions is type D, bizarre shapes are type E. And this was the era when Rashkin device was being used. So in order to fluoroscopically identifying the narrowest portion, they called, if the narrowest portion is pretracheal, paratracheal, or posttracheal. The principles were, whenever the PDA has got a restriction, it is suitable for a Rashkin device. In the current day, we identified that PDAs have got bizarre shapes. However, preterm PDA alone has got a peculiar shape of a hockey stick with a very long linear path, and so that got named as type F. What was the reason behind this classification? In that era, when it was described, the only transcatheter method of closing the ductus was Rashkin device. Device stability needed constriction. So only type A and type B were suitable because they had decent constriction. When we look at large ducts, what are the shapes? There are more types. We have the conventional narrow at PA end. We have what is narrow at aortic end. We have mid-ductal constriction. We have PDAs which are tubular and no constriction. We have elephant trunk-like PDA. We have PDAs that arise from mid-thoracic aorta and climb all the way into the thorax. We have PDAs from different origins. The right aortic arch, left innominate artery, and innominate artery is giving a large PDA. So PDA morphology is tough to classify. Size of a PDA. We need to understand PDA expands in systole. End systolic frame will record the maximum ductal dimension. Problems of device malposition may be due to errors of sizing. Next problem that happens in echocardiogram in an adult is very poor echo windows. Unlike in a child, adult echo windows are extremely inadequate for sizing a large PDA. A huge window-like ductus from an adult, which is shunting left to right, you can appreciate the markers are, these two markers are 2 centimeters apart. So this PDA itself is 2 centimeters, a large PDA. Next thing about the difficulty of hemodynamics of a large PDA, the entire PDA shunt may change very dynamically in a sick patient on administration of oxygen. A large PDA which is completely shunting right to left on oxygen intensively with respiratory physiotherapy, that same PDA starts to shunt completely left to right. Hemodynamics are fluctuant. Treatable causes like anemia, hypothyroidism, respiratory tract infection, reactive airway disease, asthma, apnea of prematurity which goes on to late preterm infants, gastroesophageal reflux, post-treatment with pulmonary vasodilator or home oxygen, vitamin B1, adenoidectomy, varieties of corrective measures may change the echocardiogram from the right to the left. Problems in angiographic assessment of a large PDA. Whenever there is a massive PDA, extremely high volumes of contrast and extremely high force of injection also will not give a decent picture at all. Some of the ways in which you can try to get a better angiogram will be a distal balloon occlusion of the thoracic aorta if it is a smaller child with a catheter like a Berman or Swan-Ganz. But if it is an extremely large patient, a large Berman catheter cannot occlude the descending aorta. So you may have to advance a large tie-shack balloon into the descending thoracic aorta, then make an angiography. The advantage is that the same balloon can be pulled back and you can try to do a balloon sizing or a balloon introcation. Single view may not show everything. This is a patient who is having a long tubular PDA. It looks as if it is coming off from here and ending here. But when you look at the right anterior oblique, it's actually starting from the mid-thoracic aorta, a long tubular course. This entire course was on the left side of the descending thoracic aorta, that the PDA looked as if it is a conventional PDA from the immediate post-subclavian portion to the main pulmonary artery. Problems in assessing shunt PVRI and operability. What golden number of PVRI is okay? We know that there is lots of fallacy. Where to take the PA sample? Is it in right pulmonary artery, left pulmonary artery, or the average of the two? Oxygen consumption is being assumed. Pulmonary vein saturations and pressures are assumed, but in genuinely hypertensive PDAs, some centers, including ours, make it a point to do a subtle puncture and take the pulmonary veins in order to truly assess what is the PVR. Stiff guide wires across the pulmonary vein, pulmonary valve can lead to PR and reduce the PA diastolic pressure and mean pressures. And so you may get a falsely lower PA pressures with thick sheets and guide wires. One of the method of assessment that is often suggested is a temporary balloon occlusion. Many people would have seen the separation, aortic pressure going up and the pulmonary artery pressure going down. What are the problems in balloon occlusion? In relatively smaller patients, you may be able to occlude the ductus completely with some small spherical balloons, which neither protrude into the aorta nor protrude into the pulmonary artery. However, in larger patients, when you use larger balloons, they either try to get melon seeded or they occlude either the descending aorta or the main pulmonary artery, or the third one is lack of stability of this balloon. Some of the ways of addressing the stability of the balloon will be to take a larger sheath deep inside the main pulmonary artery and keep it at the mouth of the balloon so that the sheath will prevent the melon seeding of the balloon. However, advancing these larger and larger sheaths through the pulmonary valve results in pulmonary regurgitation, which will alter the pulmonary artery pressures and thereby altering your assessment. Sometimes routine rules may need to be bypassed. A 24-year chronic asthmatic, heart disease was unknown, home oxygen saturation in the room air 92% in hand and 92% in leg. Echocardiogram does not show a significant LALB dilatation. There is a window like large PDA. There is a left-right shunt. However, there is no gradient between the aorta and pulmonary artery. There is a moderate tricuspid regurgitation with RV pressure predicted to be 120 to 130, the same as aortic pressure. Peak pulmonary regurgitation was 86, a huge 20 millimeter PDA. You can see the 20 millimeter PDA. Saturations in both upper and lower limbs are 91%. Because of the chronic asthma, the pulmonary vein is also desaturated with saturations being low. There is not much of step down from pulmonary vein to descending aorta, but the step up that is happening in the pulmonary artery is just about 10%. The pressures in aorta and pulmonary artery are similar. This gives a pulmonary vascular resistance of 18.9 with a PVR to SVR ratio of almost 0.6. So the pressures, they look similar. There is no difference between aortic and pulmonary artery pressure. Give oxygen for 20 minutes along with nitric oxide. You get a larger step up in pulmonary artery, Because his asthma and the lung problem has been corrected by the oxygen, the overall oxygen saturation improves. This increases the QP to 2.7. However, the pressures more or less are still high. The PVR to SVR ratio now becomes less than 0.3, even though the absolute PVRI number is 9.6. The pressure tracing, when you look, there is an absolute diastolic equalization. I have many times stressed to my fellows, diastolic equalization is the rule in the large PD. Is the rule in the large PD. If you are having a PDA which is having a lower pulmonary artery pressure than the aorta, that PDA has got a mild restriction. There should be a diastolic equalization in a large PDA. Systolic can be higher. The reason why the systolic pressure is higher is what I already mentioned as the impulse gradient. Impulse gradient is whenever there is a larger stroke volume that is being pumped from the left ventricle into the ascending aorta, the percussion wave that is created in the ascending aorta by the impulse from the left ventricle tends to lift the systolic pressure transiently. However, it cannot be maintained after the aortic valve closes, so there is an absolute equalization of diastolic pressure. It's exactly the contrary in hypertensive VSDs, where there will always be a systolic equalization and diastolic pressures can become lower in the pulmonary. Test occlusion of the ductus gave a separation. The separation was reasonably convincing, and after 10 minutes of test occlusion, there was a good amount of separation. So this VSD gets closed by a large muscular ventricular septal defect. The rules that were bypassed, absolute PVR number, PVRI on oxygen was 9.6, basal desaturation of 92%, even though both upper and lower limbs were 92% desaturated. So clinically, whether you should have taken this patient into the cath lab for all these hemodynamics, because the LA and LV did not show substantial dilatation, we need to factor in all the comorbidities that may be influencing your decision. In smaller babies, it may be bronchopulmonary dysplasia. In infants, it may be a recent RSV bronchiolitis or bronchopneumonia. In a grown-up child, it can be a chronic asthma. And in an adult, it can be COPD, emphysema, or any sort of associated lung diseases. The problems in the intervention, devices. What are the devices that are available? We do have duct occluders. The AGA's US FDA approved duct occluder goes up to 1412, but in India 1614 is available. Other makers even go up to 3028, including Lifetech. And Lepu makes 2422. Cocoon makes 2422. So larger and larger duct occluders available. Muscular VSD's largest size that is available is 24 millimeter from other vendors and 18 millimeter from Amplatzer. Vascular plugs are available. Extremely rarely septal occluders. Sizing of the ductus in a very large PDA is extremely difficult, especially if the patient is more and more of an adult. A patient who is having a 22 millimeter PDA, a window-like PDA, is getting closed with a 30, 28, the largest Lifetech PDA occluder. Now the amount of oversizing that has been done is something like 8 millimeter. In general, the rule is in very large ducts, the duct occluder should be duct diameter plus 3 to 4. But when it goes to Himalayan proportions, it sometimes may have to be 6 to 8 millimeter. When does a large device occlude a descending aorta? It is one of the concerns in smaller patients with large duct. Make it a point always to measure the ischemic area. Now, in some of the patients, in spite of having an adequate isthmus, the aortic retention skirt may protrude significantly and it may lead to obstruction. However, in older patients, aortic lumen is not an issue due to aortic dilatation. One of the methods of assessing what is the largest size that an aorta can take, we need to understand This is the isthmus diameter. The isthmus diameter is measured. The ductus has got an aortic retention skirt. So when you look at, sorry, I'll go back. When you look at the aortic retention skirt, the aortic retention skirt is going to be sitting on the circumference of the aorta. And so if your aortic retention skirt is occupying about less than 50% of the circumference of the aorta, this PDA can be closed with that particular device. This is actually the same logic that Dr. Zahid Amin will also mention about left ventricular outflow tract dimensions in patients where you are closing a perimembranous ventricular septal defect, about what should be the size of the LV disc, how large is an LV disc more than what is acceptable for the left ventricular outflow tract. So take a measurement and the aortic retention skirt should not be more than 50% of the circumference of this aorta. A 5-year-old child, 12 kilogram with a 10 millimeter PDA, aorta often accommodates. We need to understand that aorta enlarges and accommodates. When do we then exert a caution? Whenever the ductus is looking larger than the isthmic area, this is actually not a coarctation. This looks like a fallacy. It's not a coarctation at all. This is an artifact. This is the isthmus. This whole area is the isthmus, and this is the ductus. And we need to be like taking some caution whenever the ductus is looking larger than the isthmus. We need to take varying ductal shapes into consideration and try to change the device size. In general, the device size is duct narrowest end plus 2 millimeter. However, in some of the large tubular PDAs or some of the atypical PDAs, you may have to go for duct plus 4. Tubular PDAs are very difficult ducts. In fact, the paper of Kitchen, Lee, Benson, Bob Freedom mentioned tubular PDAs, since they don't have any constriction, are more likely to have rash thin device embolization. The same rule applies to any device because there is no constriction. Difficult ducts, you need to oversize a lot. So one of the problem about the positioning is the device often tends to go into bizarre shapes and very unstable positions, and we may have to take a decision about what level of an unstable position you will accept or whether you need to retrieve the device. Some ducts do not look long, I already mentioned. This is a duct on lateral view that does not look long. It actually on echocardiogram looked a very long tubular PDA, extremely long tubular PDA. But here it looks like a regular tubular PDA. So if that is the case, the PDA can be closed. The length of the PDA is not very long. However, on an RMO view, whenever you get an echocardiogram showing an extremely long duct, but an angiography is not showing such a long duct, then you utilize the right anterior oblique projections as well. In these particular patients, sometimes if it is extremely long, try for an intraductal delivery, and this is a complete intraductal delivery. Tubular PDA, as I mentioned, is challenging, and we need to view it in multiple views, and we need to be understanding how a tubular PDA actually looks. Sometimes the 2D anatomical view may not look very classical, in which case use 2D color with color or with zoom, and you can appreciate that the color flow is tubular or does not have any constrictions at all. Some PDAs could not be measured at all as they are extremely dynamic. Very, very, very large PDAs could only be sized only after you put in a device. This PDA was actually measuring 18 millimeter. It was one of the PDAs in Nepal, Himalayan country, 18 millimeters by echocardiographic measurement. Then you try to, actually this is a Berman catheter, trying to give some sort of resistance to the contrast flow into the descending thoracic aorta and retain the contrast. Now you take a large sizing balloon and try to size it. We need to understand what we are getting here as the waist is actually not a waist. It's a fold of the balloon, because the balloon is such a low compliant balloon that it just folds up in some places, giving a very artificially low waist diameter. It's actually not a waist at all. You can appreciate that it keeps on moving. The fold of the balloon is creating an artifactual impression about the waist. We put in a 24 millimeter post-MI ventricular septal defect device, and still you understand how large is this PDA. This PDA was, the angiographic measurements prior was absolutely different, whereas with the 24 millimeter post-MI VSD, it was completely different. In such tubular PDAs, even a septal occluders do not work. Large septal occluders work only when it is a large window-like PDA. If it is a tubular PDA, it doesn't work at all. Tubular PDAs in smaller babies are much more common. This is a 3-month-old baby with a small tubular PDA. And in such tubular PDAs, cylindrical device like an Amplats or vascular plug is actually good. And they're delivering it intraductally in order to avoid a protrusion into both the lumen on either side. Another question that will come whenever there is a larger PDA is, do we always need a muscular VSD, especially when the patient is having systemic pulmonary artery pressures? If there is a large shunt, it may not be needed. This is a massive PDA. The PDA measured about 20 millimeter in its expansile frame. We can appreciate how the pigtail keeps walking inside the PDA from the descending thoracic aorta, and the PDA is being closed by a 28-26 Lifetech PDA device. What happens is the large pulmonary end, when you are oversizing significantly, mushrooms out and gives the same effect like the muscular VSD. Another problem that will be doubtful will be, is the aorta going to be compromised by this generous oversizing? I mentioned that you keep on oversizing to 4 millimeter in a smaller child and sometimes even 6 to 8 millimeter in a larger patient. What actually happens? Whenever you close the PDA, there is a sudden distension of the aorta. There is a high blood pressure. It in fact makes the aorta more roomy, and the aorta balloons out following the procedure. And very large PDAs, even if the aortic retention skirt circumference was looking larger for the ischemic diameter, sometimes may be accommodated because of this distension of the aortic lumen, secondary to the sudden blood pressure surge that happens, and the aorta remodels. We need to carefully look at the aortic occlusion with large devices still, especially in very small patients. A very large PDA in a 1-month-old baby who was having features suggestive of heart failure. A larger device is being placed. Here, it looks as if it is entirely sitting on the aortic lumen. You can appreciate that this is the aorta. It looks as if it is completely sitting on the aortic lumen. Many of us who do not take an arterial puncture will at that particular point of time will only look at what is the femoral artery palpability. If the femoral artery becomes much more bounding after this closure, that means this PDA is not actually occluding, and you can appreciate here the PDA is actually on completely, the aortic retention skirt is completely outside. I'll freeze it. So this is the levo phase. So you can appreciate the ascending aorta coming down as the descending aorta here, and the device is not encroaching on the lumen. The last part of the lecture will be unusual duct morphologies. PDAs that do not enter the confluence are unusual PDAs. There was a PDA that was coming into the right pulmonary artery with a PA systolic pressure of 75 millimeters by RV systolic pressure. It was completely an isolation of the right subclavian artery. What is an isolation? The subclavian artery is not connected to the aorta, so the carotid fills the subclavian. And from that subclavian, the PDA fills the descending aorta. So in such a case, the PDA causes what is called as a double steal. The second steal will be from the subclavian artery into the pulmonary artery. So when you do an angiogram, you can appreciate that the PDA is completely not, there is no subclavian artery at all. But as you go into late levo phase, you can appreciate a large PDA that is coming back. And this PDA leads to the pulmonary artery pressure of 78 millimeters of mercury. And the moment you close the PDA, it becomes 35 millimeters. And the right arm pressure, pulse starts feeling better. The BP increases in the right arm to 95 millimeters systolic following the closure. PDA from left innominate artery. Whenever there is a right aortic arch with a large left innominate artery, again, this needs to be carefully be assessed. And these patients may often need a little larger device than what the ductus sizes come by echocardiography. In such patients, viewing with LAO and AP projections are far better. And LAO projection helps in preventing the overlap of the ductus with the left pulmonary artery. Otherwise, the ductus will get overlapped with the left pulmonary artery. Unusual clinical situations, a child with renal failure, with a massive PDA, severe renal failure, expansile, highly expansile PDA. The patient is so compromised and it is 2 centimeters. So the patient is neither suitable for a regular general anesthesia. You conceptualize the ductus. Mental 3D reprint is transferred onto the echocardiogram. So you put up a device here. Find out what is the aortic retention skirt that is needed. Find out what is the aortic diameter and the pulmonary diameter that is needed. What is the length that is needed? Take up a device of that particular size. This measurement is now translated clinically, and this is the ductus that is, the device is coming up. The moment the ductus comes and occludes, immediately you can see the bradycardia due to Nicodolani-Branham effect, and you can see the significant bradycardia and the hypertension that is happening. Fluoroscopy guides the location of aorta and PDA, but no contrast is being given. PDA in circumflex aortas are also unusual. Circumflex aorta is an aorta that goes as an ascending aorta, arches on the left and falls back on the right. So there is a retrotracheal circumflex aorta. This PDA gives a large PDA from the leftward side. You can also appreciate the aberrant right subclavian artery. You go and close this PDA with a device, and this is how the angiogram looks. The angiography now shows that this is the aberrant subclavian artery coming off separately, and this is the aberrant subclavian artery, and the PDA is being closed. Circumflex aorta. PDAs with large ductal aneurysms. You are putting actually a covered stent there. There was a massive PDA. PDA with very fluctuant PVR. This PDA was a very hypertensive PDA. You put in a muscular VSD occluder, the device completely occludes. This is a test occlusion. Here the distance is 16 millimeter. So if you want to fenestrate this particular device, you need a stent, a coronary stent through this device that is longer than 16. So we chose a 24 millimeter stent so that it will protrude on either side, both into the descending aorta and into the main pulmonary. So you take back the device, fenestrate the device with a needle, pass a guide wire, pass the guide catheter. So the guide catheter goes through this fenestration into the descending thoracic aorta. After again putting in the device, through the guide catheter, put in a coronary stent. So there is a coronary stent here, and this is the follow-up angiogram. You can see the coronary stent through and through the muscular VSD device. So this is how a fenestrated PDA device is done in some of the large PDAs. The next unusual situation, last situation, a sick 25-day, very bizarre bilateral PDA. Sick baby on ventilator. This is a right aortic arch with the PDA that is coming from the right aortic arch towards the PA confluence. So that PDA is crossed, a device is deployed in that area. Then after deploying that, we can see that this is an intraductal deployment. This is the right pulmonary artery, but you can see the ductus from the left subclavian artery is seen here. So they enter into the left subclavian artery, and this is the left subclavian artery which is isolated, and that is also flowing into the PA, causing severe PFH. So this flow from the left subclavian artery back into the PDA is causing continuous higher pulmonary artery pressures. So that PDA is now being closed, the device in place, and now you can see this is the left sided ductus being closed and the right sided ductus being closed. So PDAs can be of bizarre shape. Problems of large PDA start from definition, clinical diagnosis, echocardiography and angiography, shunt assessment and PVRI calculations. Problems occur during temporary balloon occlusions also. How to occlude what balloon. Choice of device varies from duct occluders to muscular VSDs. Extremely rarely septal occluders. Muscular VSD device is not needed in every large PDA, as an oversized ADO1 will have a similar mushroom. The reason for this is muscular VSDs are no longer available beyond 24 millimeter, but PDA devices are available up to 30, 28. Tubular ducts will need significant oversizing and, if possible, an intraductal deployment. Time constraints for today did not permit me to address large PDA in preterms and tiny infants, and which needs another discussion. Thank you very much.
Thanks, Shiva, for showing us really a large spectrum of PDA morphologies and PDA hemodynamics and your approach to addressing these PDAs. So I think we'll take a few questions from the audience. The first question is from Dr. Rajesh. How to calculate QP by QS in a patient with PDA by echo? I'm not a very great believer of finding out the QP by QS by taking the aortic annular VTI and aortic annular dimension, pulmonary annular VTI and pulmonary annular dimension, and finding out what is the left-sided cardiac output and right-sided cardiac output. Whatever is going out through the aortic annulus is the QP, and whatever is going through the pulmonary annulus is the QS. Having said that, the constraints of this particular assessment should be A, there should not be any pulmonary valve turbulence or pulmonary regurgitation, aortic valve turbulence or aortic regurgitation, and the ventricular function should be normal. Biventricular function should be normal. Whenever any of these caveats are there, the QP by QS is difficult to calculate. General rule, LA-LV is dilated, QP is large. And I think, you should take into consideration all other factors, right from clinical factors, cardiomegaly, presence of murmur, LA-LVVO, flow through the pulmonary veins. All this will give you more information rather than going through those numbers of QP by QS. I completely agree with you. The second question, Shiva, is from Dr. Srinivas. There was one patient in whom you had closed a very large PDA with systemic pulmonary artery pressure, equalization of diastolic pressures. That patient has already completed 10 years of follow-up. So he wants to know from you, what is his current status in terms of his pulmonary vascular resistance or pulmonary hypertension? Because as you know, some of these patients could have a transient fall in pulmonary artery pressure with subsequent rise, and then they behave almost like a PPH. So he's keen to know what is the follow-up of this patient.
Yeah, some of the patients between 2000 to 2010, when we had adopted the strategy of closing PDAs with the data obtained from balloon occlusion and then leaving them with very minimal medications or only with sildenafil. There were patients who had come back on follow-up and had presented with much more higher pulmonary artery pressures than what they were originally having. However, in the current era, where there are in the last about 5 to 6 years or so, with addition of bosentan and sildenafil together, if you are getting a pulmonary artery pressures of the 60s and 70s at the end of the procedure with an aorta being about 120 to 130, that means half systemic. I have a policy on routinely catheterizing them every 2 to 3 years, just like how Westerners do for every idiopathic pulmonary arterial hypertension. We do see majority of these patients will continue to hover around the same numbers of somewhere around 65, 70, 75. One of the advantages that I see by doing repeated cardiac catheterization is that it reinforces the patients that the medication continuation for a longer period is very, very important. The moment I catheterized in 2008, at least for the next 3 years, that man does not remember his groin being punctured. Then again you puncture at the end of 3 years. So you keep doing at any point of time when the pulmonary artery pressure substantially reduces, like it drops down to less than 40 systolic, then sometimes I withdraw one of the medications. There are a large number of patients who we have had a significant reduction and we have withdrawn the medications, and a small minority who continue to have pulmonary hypertension, but none of them going back to the same 120 to 130 as what it was originally.
Yeah,
of course,
that is a very...
You understand that now we all have sort of refined ourselves, and we really know feel about which patient is really not going to do well at all. So with this sort of evolution, now the patients who are presenting, who came down to 60s and 70s and again going back to 130, 140, we have not seen in the last maybe 10 years. 8 to 10 years.
I think our experience, which we reported in analysis, is more or less similar, where they go, where they become definitely subsystemic, although may not normalize, but certainly do well symptomatically and also in terms of pulmonary hemodynamics. But pulmonary vasodilator therapy can go long-term and sometimes maybe even lifelong. We don't know that. Another question from Dr. Mahmood is how much gradient in LPA is acceptable while closing a large PDA? To that, my corollary is that, Shiva, is it your routine practice to measure gradient across left pulmonary artery in every patient of large PDA, or you go angiographically to know, or with the help of an echo in the cath lab to find out how the left pulmonary artery is behaving vis-a-vis the device?
Yeah, whenever there is PDA that is being assessed in the initial clinic on echocardiography, the left pulmonary artery will be measured. It is very well known that almost about 10 an associated left pulmonary artery narrowing, and you document it. After this documentation, then you go ahead and position the device and look at the post-device LPA velocities. If the velocities exceed more than 2 meters per second or 16 millimeters of mercury, and if your original diagnosis was already an LPA artery which was borderline hypoplasia, then I switch over to LAO 30-30 or LAO 40-40, something like a shallow LAO, steeper cranial, and do a sheath injection with a large volume of contrast in order to visualize the left pulmonary artery very well. If the left pulmonary artery lumen is reasonably good, which means having made the initial measurement of an LPA hypoplasia right at the initial diagnosis itself, if that left pulmonary artery is not looking extremely pinched, then we leave the device. We, in fact, prior to the procedure, we explain to, most important thing is to explain to your team members, this is the baseline LPA number. This is the baseline LPA diameter. So we all understand what is the baseline LPA. One of the problem in echocardiography post-procedure is the metal that is sitting on the top of the LPA does not allow you to get the same degree of measurement ability. The spatial resolution of the echocardiogram of the LPA origin fails at the end of keeping a large device. So by and large, you may have to go by what is the gradient. And if it is more than 2 meters per second, then it is something of caution. You either reposition the device or change the type of device. For example, originally you have taken an AVP2, then you change it over to an ADO1. You make the device modified in such a way that you don't encroach onto the pulmonary artery complex.
My question to you on this aspect is that sometimes when the device is on the cable, you may not get significant LPA gradients, especially many times with long PDAs, you are using a ADO2, for example, with a long pulmonary artery disc. The moment you release the disc, the device tends to get into the left pulmonary artery. Would you like to comment? And that is true even on the aortic side. Many of the angiograms that you showed, where the aortic retention skirt was protruding into the aorta, but non-obstructive, most of the time the devices were on cable. But you will be surprised that there is so much of recoil that you may get gradients after you release it, and by that time it is too late. So would you like to comment on this experience of post-release gradients on the pulmonary and the aortic side?
Sure. The fundamental difference between an aortic occlusion and the left pulmonary occlusion in a large PDA, when we are holding the device from the venous end with the cable is exerting something like a forward tension on the device and trying to pull the device towards the pulmonary artery. So we try to miss an aortic gradient, and the moment you release it, the PDA recoils it back to its original location, which is far more posterior, and so you get an aortic gradient. However, such a phenomenon does not happen on the pulmonary end because we are actually holding the ductus from the pulmonary end. I have not seen a PDA, a LPA narrowing that was not present when the device was held by the cable, but only manifesting after. Having said that, let me also add one point. There were patients in whom the PDA, the left pulmonary artery gradients came up to close to 2 meters per second. We decided to accept them. While in a majority of the patient, the LPA sort of grows bigger and bigger, and the LPA gradient remains either stable at the same 2 meters per second or progressively falls down. There are a small minority where the ductus will encroach, the LPA stenosis will get more and more. This is often seen in the extremely tiny babies, where I feel the process of ductal constriction that normally causes an LPA or LPA origin coarctation, even in the normal situation, acts there with a little bit more of vengeance, and this may happen. So in extremely small babies, if there is a gradient that is touching 2 meters per second, and if the angiography is not looking very satisfactory, that is one of the risk factors for creating a future permanent left pulmonary artery stenosis. Otherwise, the large number of left pulmonary arteries tend to grow with time.
There are multiple questions, but in the interest of time, I'm going to cut short because there are a few questions on how to put a stent in the muscular vein. I think it is such a rare thing that the people who have asked these questions regarding the technique of putting a stent within the device, I think they will communicate with you directly.
Not a problem. Actually, I will also keep looking at the chat box, and I will try to find out. Actually, there was yesterday a request from Anil Singhi, Nageswara, Dr. KK that please give your names. If the name is there, be assured within 24 hours you'll get a message from me.
Correct. So that would be, I think, in the interest of time, we can do this. The last question to you is, what are the chances of device embolization when you do an intraductal delivery? And especially, Shiva, I want to add to this. I saw 2 or 3 patients of yours where you have used an ADO1 device. You have done an intraductal delivery with some kind of retention disc, which was not looking like a retention disc. You know, I would call it a disfigurement of the aortic retention disc. And that really worries me because there may be a melancy defect and this device might embolize. So could you just, within a minute or so, comment on this, the chances of embolization with disfigurement of aortic retention?
Yeah, usually we have seen device embolization that are happening in relatively smaller patients, smaller ductus. I'm telling about smaller device sizes, which means, like, for example, an 8.6 or a 10.8, they tend to embolize more, or a 10 millimeter AVP2, they tend to embolize more. 24 millimeter, 26 millimeter, 28 millimeter do not embolize because already we are now breaching that cutoff of +2. We are going to +4, sometimes +6, sometimes very, very rarely. For example, a 22 millimeter device being close to the 30-28 device. So embolization was not an issue in the extremely larger devices, but that is a genuine problem in extremely smaller devices. Majority of the time, whenever there is a very long tubular PD and when we try to do an intraductal deployment, always it embolizes into the pulmonary artery. Okay? Always it embolizes into the pulmonary artery. In fact, one of the practice that I follow is an extremely tubular, very, very, very long PDA. If I am putting in a device, I don't remove the sheath. I pull it down up to the inferior vena cava and leave it there. Keep the child for the next 2 to 3 hours in the recovery room and wait for the heparin effect to completely go away and the ductus to completely clot, and show that absolutely there is no color flow at all, and then only try to take the sheath out. The problem was always whenever this embolization has happened, It was happening all within, by the time I complete my next case, the previous device is embolized. So it is reasonably acute. It does not happen after a lot of fibrin and thrombin gets deposited over the device and the flow stops. It's the flow that causes embolization. Once the flow stops, usually it remains intraductal delivery. If the flow stops, usually they remain stable. Late embolizations,
Now I'll have 1 minute comments from either Nageswara or from Radha or from KK. One of the anyone from the audience can just comment. So I'll start with Nageswara. Would you like to make any comments, Nageswara? I think he's muted. Radha, would you like to make any comments on whatever that Shiva presented?
Sometimes it was a very good talk, a wonderful collection of PDAs. Sometimes when we have a large PDA, especially in adults, you had pointed out the difficulty in sizing by using balloon technique and all. What we would do is probably do a CT in order to visualize the duct much better and not struggle with these angiography, because howsoever volume you might give, especially if it is a large left to right shunt, you're never able to visualize these things so clearly. But the CT sorts out that problem, I feel.
But rather, CT sorts out
one point in that area. Yes, CT is a mixture of systolic and diastolic images together. So that also we need to take into consideration. And second thing is, gross amount of expansile nature of certain ducts are tough to be assessed. But I fully appreciate your point, Dr. Radha. If you are getting something like a 20 millimeter on a CT, I think you should try to target a 28, 26 or a 26, 24 or something. Like you need to be very liberal.
You are doing an angiogram after temporary occlusion of the duct, so you have an idea. But at least to start with, you have a much more accurate idea of what the possible size would be of the PDA.
Anatomy, I think for CT would be very good, but pulsatility is an issue. So I think KK wanted to say something. He has a very huge experience of PDA closures. KK, over to you, please.
No, I don't have too much to add. I just wanted to tell you that it's not a good idea to assume that your post-PA pressures after high PVR duct occlusions will stay that way, even with pulmonary vasodilators. In the last 2 years, I've seen 3 patients die, some of which were done when Shiva was here, and all of whom were on pulmonary vasodilators. And this has happened 15 years after the procedure. So the story is not over with PAH. And all these people had half systemic PA pressures at the end of duct occlusion by the device, early cases. We followed them. 5 years later, they were okay. 10 years later, PA pressure started to rise. 15 years later, refractory heart failure, 2 sudden cardiac deaths, refractory to all pulmonary vasodilators. So I think Dr. Kothari's dictum eventually may turn out right. When in doubt, don't close these ducts. I think will turn out right. I've also been stenting ducts within and leaving a fenestration whenever I have had serious doubt. I think that's a reasonable ploy. You have to be very sure that the stent stays open. You have to put in a relatively larger stent to fenestrate the device, but that may be a better ploy than trying to trust these vasodilators.
Yeah, I totally agree with you, KK. Actually, I would like to say some of the principles of cardiac catheterization and interventions were actually taught to me by KK. So I'm sure when we are talking about the closure of a duct with a higher pulmonary vascular resistance and a high pulmonary artery pressures, the basic principles all hold good. We look at it extremely closely. Probably these patients will take a much larger time to take a decision and make a game plan than many of the routine interventions that we do. And I fully endorse that view that unless you are going to be meticulously following that patient and take that patient very repeatedly coming back to you for very frequent follow-ups, this strategy should not be adopted at all.
I think
I would like to comment, and then I would like to introduce Dr. Sreeram afterwards. See, my comment is we adopted a new strategy now. I totally agree with the KK's view. But what we are doing is we are doing a PDA banding.
Yes.
So we do PDA banding. We have done some cases of which 50% of the cases, they have still right to left front actually. Their right heart is dilated, they develop a pericardial effusion. It is not that easy. I also agree with what Shiva is telling, putting and then long-term follow-up, we don't know all these things. So whenever you have a doubt, it's a better not to close or you adopt a situation of a PDA banding. Second thing is a tubular duct in a small baby is quite challenging technically. Whatever device you use, either it is AVP1 or tubular duct device, whatever it is difficult. That's my comment to this. And now I request Dr. Bharat to introduce Dr. Sreeram. He is connected and he is waiting. You all can see him.
Second speaker, Sreeram.
With the interest of time and he logged in. So it's very difficult to coordinate from Germany to India. That's why I request Jayranganath to have his talk after Dr. Sreeram, if it is okay with everybody.
Yeah, I think it should be okay. And I think with this, I think we will conclude this session with a last comment that remember one thing, that these are technically very demanding cases which Shiva showed. And there is an alternative to some of these cases called as surgery. So don't forget that there is surgical closure of PDAs as well. So don't think that device is the only way to go, because some of these can be technically very challenging and you may get into serious problems. So I think, thank you, Shiva. With that, we'll move on to the next talk, which will be on personal protection devices for the pediatric cardiologists in the current era of COVID pandemic, which will be delivered by Sreeram from Germany. Over to you, Sreeram, and welcome to this third edition of Transcatheter Intervention in Congenital Heart Diseases.
Good morning, Bharat. Thank you.
Dr. Sreeram, can you share your slide, please?
You have my slides, Nagesh.
Okay, I will.
No, you can share it from your system itself. On the bottom center, there is a share screen of the Zoom.
Why don't we not waste too much time, because it took me a very long time to get this far.
Okay.
And you know, I can just present what's in my slides to you straight away from the top of my head.
Right.
Yeah, I will share slides of Dr. Sreeram.
Sure.
So just let me find out where is the Zoom. Zoom is disappearing here. So can you see me?
I can see you very clearly. I can see all the other participants.
Yeah, I can see everything, but where is the...
Okay. In fact, that's why I sent the PowerPoint to you yesterday, because I'm not technically...
Can somebody share my PowerPoints? I have PowerPoint here. I opened the PowerPoint. Can you see my PowerPoint?
I can't.
Not yet, sir.
We can't.
Or else, like, if you can, like, send it to me, sir, I can show it on the screen.
Yeah, 1 second. Now we are in meeting.
Yeah.
I am sharing my screen. Yes.
Sure, sir. Thank you.
So did you see my screen?
Yes, sir.
Yes, we can see.
Oh, yes, I see it.
Yeah.
I see it.
Now you can go ahead.
Okay. The most important things are that we seem to have the lowest incidence of corona all through Europe. And there's a lot of questions about why that might be the case. And I think the biggest difference between Germany and other European countries is we started testing in early January. We took it seriously, and any person with a fever and a cough was actually tested by a PCR. And the results of this PCR is usually available on the same day. So if you take the sample in the morning, by evening, you have an answer. And this, in fact, has guided our practice, because what we do now is we have virtual outpatient clinics, so we don't actually see the patient. We have a list of 30 or 40 patients who are scheduled for the next day, and we call them 1 day in advance, and we try and cancel as many of them as possible with just a telephone consultation, which leaves us with a small workload, which means we are able to keep social distancing in a very strict way. And what we have done is apart from canceling outpatient clinics, we are down to only doing emergencies in the cath lab. We are down to doing only emergencies for surgery. And everybody who walks into the intensive care has a complete PPE. Now I have a photo of this on my telephone, but I can just describe it to you. So this means a visor that goes down from the forehead and covers the eyes and the mouth all the way down. You have a full protective equipment, so it goes all the way around you, and you wear sterile gloves. And you do this when you go in and out of each room. So if you have 4 people visiting a patient on ICU, all 4 have to wear this, and all 4 have to throw it away when they come out. So it's a big organization to get it done. But that's how we're working at the moment. And what we have also added to this, and this is from this week, this is a directive from the government, is that all elective patients or patients who are planned already for something, they have to be tested for corona 2 days in advance. So they have to come once to the hospital, they get a PCR, and only if that's negative, then the procedure goes ahead. And that is in effect from this week. So in a way, our workload has diminished considerably, but the most important thing is we are keeping social distancing. And social distancing, I put 1.5 meters on the slide, but it's now 2 meters. So you really take a very wide berth from everybody. So even if when we have a meeting, now the way you are sitting, Nagesh, it's already wrong. And people who are not absolutely essential have to just leave the room. And this applies not just for us. Now, you can't walk into a supermarket in Germany without social distancing. So once the certain number of people have been inside, so it depends on the size of the shop. So if a shop can accommodate only 5 people with a 2 meter distance, the rest have to just queue outside at a 2 meter distance from each other. And this is all policed by the people themselves. So the nice thing is there is not somebody with a lathi waiting to maintain order. And this is why we have mortality, which is around the 1%, slightly less at the moment. And in a way, for us, it's not different from a standard winter flu, the way it has affected Germany at the moment. If with a standard flu, we have a mortality of about 0.5 to 0.6%. And corona is probably just only slightly higher, 0.9. So I'm happy to answer questions. This is what we do. This is how we do it. And I'm happy to take questions.
Yeah, thank you, Sreeram, for sharing your experience of the kind of protocol that you follow in Germany as far as the pediatric cardiology programs are concerned. So let me begin by asking you, and then I'll share this with my fellow panelists if they have any questions. The first question is that you said that you are still doing elective procedures with corona testing. Do I understand you correctly?
Yes, we are doing elective procedures now with corona testing, and the testing is done 2 days in advance.
My question to you is, which was there, when we started testing for HIV also, that if you are in that incubation period of 7 to 14 days, when your test can still be negative, and yet you can be one of the carriers. Does it happen that way even with this PCR testing, or that is true only for antibody testing?
I think it's more likely to be true for antibody testing, but there are loopholes. We still don't know how accurate the test is. The nice thing is we are able to offer at this moment something like 500,000 tests a week. So pretty quickly we would have covered a critical mass of the German population. And the other important thing is these tests are actually paid by the insurance. So the threshold for joining or for having the test done is very, very low because it is paid by the insurance. And there are over 400 testing centers throughout the country. So it's not a major problem to drive to one of them. Yes, KK.
Hi, Sreeram, nice to see you. I just think, Nageswara, it's probably essential to introduce Sreeram. There's a different group of audience this time who are not familiar with where he is and what he is doing. It's important for the context of this talk.
Okay.
I'll do it for you. Sreeram is from Cologne. He lives in Netherlands, but works in Cologne, Germany, and is one of the very busy programs of 4th busiest. Am I right, Sreeram?
Yes, yes.
in Germany, and we really are lucky to get your perspective. It's so wonderful for you to have joined us, and hopefully with every episode of our this session that we are having, we'll have more and more international stalwarts join us. Quickly, Sreeram,
Yes.
we can't afford that level of testing in India.
No.
So I'll just share with you the Kerala perspective. COVID came to India first into Kerala, straight from Wuhan, through 3 medical students. It happened before any other part of the country. Yet, right now in Kerala, we have about 350 cases and 2 mortalities. We can't test on the same scale as Germany, but it's been better than anywhere else in the country, but nowhere close to what Germany it is. So the way that Kerala has done this is through contact tracing. They have identified every single potential COVID person, everybody who's returned from abroad, isolated them, isolated their contacts. So we have about 150,000 people on some kind of surveillance all across Kerala. And of course, tremendous amount of public health involvement. Every single personnel in the public health system is into this. And great degree of public health awareness, daily updates from the Chief Minister. All this together has, I think, resulted, at least for now, in plateauing of the cases. And we've been overtaken by every other state. If you see the COVID live updates, Kerala is now number 5 or number 6. We started off as number 1 in terms of number of cases. Now, the number of cases is a very poor indicator in India, but number of deaths has been quite reassuring. Just 2 deaths so far. So we have to come up with low-cost solutions, low-cost PPEs, re-sterilizable PPEs, and we're working on all that in India. Hopefully, we'll be ready when the epidemic truly hits us, which it is going to, I guess.
I think I have to make 2 points about what you said. And the first one is we're all depending on forming some kind of herd immunity, because this whole idea of social distancing, keeping distance, is based on trying to reduce the number of admissions to intensive care for people needing ventilation, because there's a limited number, there's an absolute number of how many people can be ventilated. So it's a way of spreading out the disease over a longer period of time. And I think the biggest issue will be, when do we restart normal business? Now, already in Germany, all the colleges and universities are closed, and this academic year is basically lost. And I think it's fair to say that people can only rejoin studies in September. But even then, we are proposing that we need to have an antibody test to see what degree of herd immunity has been achieved. And this is my biggest question for centers or countries that do not test. At what point do you decide it's okay for people to start meeting one another?
Yeah, I think that remains a million-dollar question, and I don't think that there are very, very easy answers to that. It will depend upon probably the prevalence of the disease or exposure in the given population.
But that's the question. If you don't test, you don't know that.
Yeah, absolutely. And it is very unlikely that most of the developing countries will find it extremely difficult to test to the same level as the developed countries. And I think that it is going to be difficult in deciding when to lift up this lockdown and how to lift up this lockdown. It's not going to be a very easy decision for the governments, because you can be damned if you do it and you can be damned if you don't. It has very significant implications on the economy of the country because of the businesses running down and because of the lockdown.
You see, you're absolutely right, because in a way, all we've done so far has been a knee-jerk response. We first started with thinking, okay, let's have herd immunity, let's just have the infection spread around the world. Suddenly that wasn't possible because the mortality was too high, so we've pulled back from that. Now we're back to let's isolate and try and spread out the duration of the disease and reduce the numbers of people infected at a given time. Which means, in theory, it might take a year or 2 before this goes around the world and you have 70% infection rate to say now we have herd immunity. And do we have, I don't think anybody can wait that long.
I mean, hoping against hope, probably everybody must be looking at either some therapeutics or some vaccine coming up in near future, and probably, getting us out of this problem of distancing as well as lockdowns. There are a few questions from the audience. Sreeram, one of the questions is that you people who are on the front line, are you taking any prophylaxis in terms of?
No. And even the people working in the dedicated corona wards, in fact, we have at the moment 64 ICU beds which are set apart for corona patients. So we can ventilate in my hospital 64 patients. And of these, at the moment, 21 are occupied. So we have a system where people only come to us in case they're being considered for ventilation. If they're not sick enough to be considered for ventilation, they don't even come to our hospital. So we send them away to other places. So that's our occupancy at the moment. So we are running at about third capacity, and even the people who work in these dedicated wards do not have or do not take personal prophylaxis, because I think the evidence is not there.
Any of the patients in pediatric practice, either your own or from the colleagues that you have talked to, is the incidence really low in children as compared to adults, and the natural history of the disease is less severe or more benign as compared to adults? Can you give us some idea as to what is happening in pediatric population in Germany?
Yes, we started testing in January. So far between January and now, we have identified 2 children who actually came with asymptomatic swab-proven corona. Both of them were sent home immediately, and the staff member who saw both of them went straight into social isolation for 2 weeks, and neither of them developed a clinical disease. So this is from a pediatric cardiology perspective, 2 asymptomatic people who remained asymptomatic.
One other question from Dr. Ramakrishna is, as soon as you enter the hospital, do you get into PPE directly?
No.
Or till such time you are interacting with the patient and the family that you...
No, you get into the hospital, the first thing you do is there's a big antiseptic dispenser, so you make sure your hands are clean. There's a box waiting with masks. Now, in the beginning, these used to be unguarded, and then they used to disappear. So now there's a watchman looking after the box of masks and the antiseptic dispenser. And you do the same before you step into the ward, and it's only when you go into the intensive care unit, you need full PPE.
So what happens?
We are also considering re-sterilizing PPE equipment. There's no reason to throw away good material.
So when the patient comes into the emergency room, every patient who comes to the emergency room is treated as if he is COVID
positive. As if it is corona positive, correct.
Okay, so whether you do an echo, whether you do a consult, you have to be with PPE.
Absolutely.
One question from Dr. Avasthi is, what is the experience of COVID in patients with congenital heart disease? Do they have any more propensity, less propensity?
We don't have the data to comment on that one way or the other. Like I said, we had 2 of them come in asymptomatic, we sent them away, and they remain good. They remain fine.
Over to my other colleagues to go ahead and ask questions. Nageswara, go ahead.
Do you see any involvement of myocardium, any cardiomyopathy like a picture?
I think this must be the case. If you look at the number of acute deaths in Southern Europe, it can't all just be respiratory. I'm sure there's an element of acute myocarditis, which nobody seems to be talking about.
As a matter of fact, Nageswara, if you talk to your adult colleagues, they will tell you that so many of them present like acute coronary syndromes with ST elevation MI and with elevated troponin, only to be found that they have normal or near normal coronaries with a myocarditis-like picture. So it is definitely not uncommon, and a lot of morbidity and mortality is related to myocardial involvement apart from the pulmonary involvement. KK, do you have any comment or a question? Please demute KK.
I think Shiva had a question, so I think you should ask.
Sorry, Shiva, I didn't see you. Shiva, go ahead.
For spending time with us. Just one curious question. Since you have visited India many times, you know that...
I was in India actually when just one day before quarantine would have started. I came to India, to Kochi, in fact, on the 10th of March to attend a Stanley 76 reunion. So we had our reunion in Kodai. And on the morning I landed in Kochi, they said, oh, from 8 o'clock, we have Corona quarantine. I said, well, I landed at 1 o'clock in the morning in Mumbai. They didn't stop me, and it's not fair now for you to stop me here. And he said, sir, go quickly. And I went very quickly. And yes, I'm aware of the situation.
Thank God you are safe. The amount of social bonding and the family bonding, the community bonding that is seen in Indian subcontinent compared to what it is in Germany, where there's quite a lot of people around in the roads, in the hospitals. This maintenance of 1.5 meter and variety of other things that you talk about in Germany, it'll be little difficult for us to practice. But just one curious question. Let us assume that we get some sort of funding and we are getting an ability to test 1 million persons every day. What do they do with all the coveralls that every person is wearing and the shield that he's wearing, and he's going and taking a swab, and where does he throw it out, and how that amount of biological waste that is generated in a country like ours with more than 1.3 billion, where are we going to dump? Actually, in the last 4 years, we started avoiding polythene. Now this is going to be a huge PPE that is going to be thrown out. I don't know how we are going to test a massive population, even if kits are just given.
Well, two issues there. I think we shouldn't be throwing any of this material out. I think it's perfectly reusable, and there's now evidence to show if you can dry it properly, it is reusable, that you can kill this coronavirus by re-sterilization. So I don't think we should be throwing material out. I think we're still living in a throwaway culture here, but that will change. The amount of material being thrown away is just shocking. The other thing about social distancing, and I can tell you about my own family, we have 4 girls and they all are outside of the house, so they're all adults. And we make sure that, and 2 of them are doctors, and neither of them comes home anymore because they are living in their own vulnerable corona environment, and we don't want to mix their environment with mine. So the only reason I'm able to go home at the end of the week from Germany is because none of my children comes home. And the day some of them say, we want to come home, I can't go home because I can't take the risk of mixing 2 subsets of potentially infective material with each other. So that's how we live. So at the moment, we don't even see our children. And I think that's a very sensible precaution to take.
And Saurabh has got a question. And also, Dr. Sreeram, can I share your email address? Some people are asking your email.
Sure.
Yeah, Dr. Sreeram, thank you so much for being with us. You have some experience with ventilating some of these kids or patients with COVID, because
Yes,
some of the people believe that it is unlike ARDS, and there was some discussion. I think Dr. Krishna Kumar is well aware of that. And if some people have proposed that the change is not at the level of alveoli, rather there is some change in the heme moiety of the hemoglobin, which to my mind seems quite like methemoglobinemia. So do we try some of those strategies? And as far as I know, right now, some people at AIMS are proposing some trials in which they are trying to do 10 cases each for exchange versus non-exchange transfusion. So do you have any sort of...
Most of our experience is on adults. So I have to share their experience with you. What I see from a distance is we don't actually do anything apart from standard ventilation. We don't do things like plasmapheresis or anything new. But what we do see is that the average ventilation time is almost 3 weeks. So this means that we have now just about sent our first 2 survivors home from hospital. And the mortality is about 50%. Now, why that is debatable. I can't answer that question, but maybe in an update I can. But they are occupying beds and staying there.
Yeah, because continuing with the same thought of pathogenesis, some people have also reported benefits with heparin infusion, which makes kind of linking these things together, whereby heparin is taking care of those microthrombi which are happening in the pulmonary circuit. And then this ventilation is tiding over that period in which that oxygenation issue is being settled. But usually, even in ARDS, we don't see regularly patients requiring such a long ventilation. Quite a few of them improves much faster. So that way, it seems that it may be slightly different than the standard non-cardiac ARDS.
I'm sure it's different because like I said, up to 3 weeks on a ventilator is not normal, and 50% plus mortality is not normal.
Thank you.
And therefore, entering the intensive care, we have a very high threshold for putting people on a ventilator, with the assumption that once they do go on a ventilator, then the chance of survival is less than 50-50.
Yeah, that's the scare actually. I think all the setup should be first knowing this, that ventilation, thinking of ventilation is a serious business in this time. So we should be very careful in deciding when to start ventilation, because this is a point of kind of no return in half of them. So it's
and in a way, we are fortunate because Germany has something like 28,000 ventilators. And I asked why this was the case. And it's actually a remnant from the Cold War. So when NATO was preparing for an attack by the Warsaw Pact, the battleground was thought to be Germany. And therefore, they built up a lot of capacity for intensive care in Germany. And luckily, nobody threw away these ventilators.
But are these ventilators from the Cold War still well maintained and still working? Because that is surprising, because I read in some of the American press that they had ventilators, but 70%, 75% were just dysfunctional.
No, but that is just planned obsolescence. Ventilator is just a machine. And
another question from one of the audience was, how do you sterilize the echo probes after you have done an echo in a child for whatever reasons?
Just with standard antiseptic solution.
No spatial sterilization?
No.
So are there any more questions? If there are not, I must thank you for sharing your experience, Sreeram, and giving us some insight into COVID problems in patients with congenital heart diseases, as well as in pediatric population in Germany. I think they will definitely come handy. Although the setting is completely different, the socio-economics is very different, but there is always something to learn from other groups and from other centers. Thank you.
Well, I'm just fortunate to be here, or unfortunate to be here. So I'm just in the middle of something which is not in my control either. So I'm very happy to share whatever insights we have.
Really, thank you very much. It's wonderful. And you shared your family story as well. Your daughter is working in a COVID unit, COVID social worker, whatever it is. It is really useful, whatever your discussion. Maybe we'll get back to you, and then we'd like to involve you in further future meetings as well. Thank you.
Thank you. Bye. Now I have to wear this and go back to work. Bye.
Bharat sir, you can coordinate the rest of it.
So I think now we'll move on to the last talk of this session, which will be delivered by Jayranganath, who will be talking to us on his experience in closure of rupture sinus of Valsalva. And he's going to discuss some of his interesting cases or some of his difficult cases. Over to you, Jay.
Thank you, Dr. Bharat. So it was nice 2 talks. The first one was the masterly talk by Sivakumar, and then a very innovative and very nice experience by Sreeram, our friend. So the topic was given to me by Nageswara was interesting cases, but I think we should know a bit of basics of this RSOV, or rupture of sinus Valsalva, because it's not very commonly encountered by majority of the cardiologists. We do come across, but not very frequently. It's not such a common condition. So what is important in the RSOV is that we should have knowledge of the anatomy. I'll spend a few minutes of that. The imaging, the practical imaging, and establishing the diagnosis. This is extremely important. The hardware selection and the procedural steps. So what is the meaning of this RSOV? It is separation of the aortic media from the annular fibrosis, and there's a causation of the unusable sinus. It protrudes and it ruptures. It causes the rupture of sinus of Valsalva. It is not a new one. It is reported way back in 1839. This constitutes 1% of all the congenital heart defects. So usually in our series also, it is more or less the same thing. Is a male or more preponderance in the statistical thing series. And although congenital, most rupture in the second and third decade. Anywhere in our series, it's 11 to 67 years. The first case, in fact, of my own personal experience done with my colleagues, senior colleagues, in 2005, in a girl, a 11-year-old girl, that's why I put 11 years. She came with a heart failure, with a renal failure. What are the associations? The VSDs are not uncommon with RSOVs. It constitutes 15 to 20%, and with the right sinus involvement predominantly. The aortic curves, prolapse, and aortic regurgitation may coexist. The other coarctations, bicuspid valve, other associations. So what are the distribution of the aneurysms? Majority of the aneurysms seen in our series is same from the right sinus, right coronary sinus. The rest are from the coronary, non-coronary sinus. Left is extremely rare. And most of the times what I have encountered, 2 cases, they're all acquired, they're not congenital. So this is a very nice slide. You show this, please observe this slide carefully. NC, non-coronary, R means right sinus, and the left is left coronary sinus. You could easily make that non-coronary sinus will never rupture into the RV. It almost always ruptures into the right atrium. Even in our series is the same thing. But the right coronary sinus, either it could rupture into the right atrium, when most of the time when it ruptures into the right atrium, it near the tricuspid valve. And it can rupture into the RV and the RVOT. Very rare sites of rupture into the PA, and which I have never encountered. This is a very old classification in the world overall congenital books. You could see this. Type 1 means a rupture of the right portion of the right sinus into the RVOT. This is a subpulmonic VSDs quite often. This is one particular subset where we encounter the presence of the subpulmonic VSD. Type 2 is in the middle portion of the right sinus into the RV. VSD is uncommon here. The type 3 is the middle portion of the right sinus into the RV inflow or into the RA. VSD is once again uncommon. So some of these RSOVs can be associated with, apart from the subpulmonic VSDs seen in our settings, we have come across some of the perimembranous VSDs. That could happen with the even the non-coronary rupturing, but it's extremely rare. So rupture of the non-coronary sinus into the RA and VSDs almost I can say I have not encountered in our big series. So imaging, coming to this transthoracic echo, of course, the clinical suspicion will make you a diagnosis of RSOV. If somebody comes with some chest pain, heart failure symptoms, right heart failure and left heart failure, you have a continuous murmur of the chest, you can suspect that the person may be having a RSOV. Transvagal echo is a must before planning this procedure, either before the procedure or intra-procedure. It is very, very important. It gives a lot of clue, unless it's an emergency. The 3D echo, which I don't have much experience, I don't think it is really important in the management of this RSOV. Cine angiography, when you are planning the procedure, definitely does. Otherwise, if you are sending the patient for surgery, cine angiography is rarely necessary, except in adults where you need to have the other imaging, like coronary artery imaging. So establishing the diagnosis is extremely important. Identify the sinus involved, which I told you why it is important, because the previous slides I did show you that the site of ruptures. Identify the site of the rupture. Multiple openings are not uncommon. Look for the extent of the aneurysmal tissue outpouching. A lot of redundant tissues, which is outpouching into. Device may not be an idea. Device may not hold. In fact, in a couple of cases, we have failed in because they were long extent of the aneurysmal outpouching with a lot of tissue. Most appear as wind socks with more or one opening. This is quite common. So here you could see that. The left and the first one, you could see from the sinus, it is opening to the RV. This is from the right sinus. This is a T picture, how nicely it's see. This is how the D picture. You could see the pulmonary RVOT. You can see the aorta in the middle. It is opening to the coronary sinus into the right atrium. As I told you, the T is absolutely important. You see here a lot of redundant tissue. You see some, it is possibly somebody might mistake it for a prolapse of the tricuspid valve or a redundant tissue of the septal leaflet of the tricuspid valve. No, it is a outpouching of the RSOV. These are all various echo pictures. This is how it looks like. A large shunt opening into the RVOT. Large aneurysmal tissue, an excess aneurysmal tissue. It makes a problem for us to close many times. Don't think that every single RSOV can be closed with a device, which is not possible. There are some certain, as Dr. Bharat told you, that something called a surgery, which is a very, very simple surgery. These are some nice pictures of the opening into the RV. You could see that from the sinus. So what are the differential diagnosis? The commonest differential diagnosis, we need to differentiate between VST and RSOV. Though RSOVs, as I told you, that they can be associated with the perimembranous or subpulmonic VSTs. The clinically, if we get a only systolic murmur, it definitely the RSOV is ruled out. If there is a continuous murmur, there the problem arises. Then is there an associated VST is there or not? So if you want to differentiate between the VST and RSOV on the color flow mapping and as the continuous wave Doppler, if you get a continuous wave Doppler, it is a continuous flow, that means there is an RSOV along with maybe VST may be there. If you don't get a continuous wave Doppler in the color flow, that's a continuous kind of a thing. It is both systolic and diastolic. A continuous wave Doppler, that means it's only a systolic wave, it is a VST. Associated VSTs may be difficult to exclude at the time of so we need to differentiate, or we need to have the associated VST delineation in the TE or the LV angiogram. Even then, TE of course will give a very nice picture of the VST, no question about it. So the LV angiogram may be necessary at times, but all these things would have planned before doing the procedure. Assess the aorticus prolapse and the extent of the heart. This is extremely important. If the aorticus is too much of prolapse is happening, whatever the device you put, I think it causes, if there is already existing ER, it will increase the ER. Though this is very extremely important before planning the procedure. The tunnel is another differential diagnosis. The aortic LV tunnel here is not very difficult. The origin above the sinus, and the absence of the dilated coronary sinus and anterior position. This is not extremely difficult once again. That is why understanding the anatomy is extremely important. The suitability for the device closure. The diagnosis of the RSOV is established by various methods like the clinical diagnosis and as well as the echocardiac diagnosis. But please remember, all RSOVs need closure. Even if it is a small one, I think one day or the rupture, it is going to increase in the rupture size. It is going to cause hemodynamics. So even if it's a small, tiny rupture, they need to be closed. And it is not very difficult to close. NYHA class 4 symptoms, we have come across in this large cohort of patients. We have done even an emergency as about 4 to 5 cases. We have taken them as like a primary angioplasty where they do in adults, like emergency closure without being waited for too long. Associated small to moderate size perimembranous VSTs can be closed, but they are far few. Only we must have closed 1 or 2. Subpulmonic VSTs we have never attempted. If that is the case, then we have referred them for surgery. Not suitable for device. As I told you, if there is a more than 2 sites of rupture, if it's a wide, a long rupture, a large wind sac, a huge rupture, huge shunt, then I think the surgical thing is possibly, excuse me. So it is not easy to close with a device. So I think we should not attempt to closure if it is too large. And if you think that we may not be able to do justice. Aortic regurgitation more than grade 1, I don't think we should do closure with a device. I think it is going to increase in majority of the cases. So I think 1 or 2 in the initial stage, initial thing of our about 7-8 years back we attempted. I know that it has worsened the grade 1, so I think we have closed. We are sent for surgery. Severely redundant aneurysm tissue, we are not be able to close. Associated defects with needing surgical correction like a VST, I think we have referred for surgery. Active endocarditis, no business to close with the device. Steps in device closure, I think femoral arterial and venous access both are important. Bilateral femoral arterial access and retrograde approach means coming from the aorta, like what do we do a VST closure using ADO2, that standard approach can be used in, but it is not really needed in majority of the cases, but sometimes it has got a role when we don't have all the hardware, when you are in an emergency, when they are technically not very trained to do the standard approach, then you can easily go and enter the, very easy to cross the RSOVs. And I'll show one picture about that. The heparinization, a standard heparinization. The pictile aortogram is necessary in the 2 orthogonal Valsalva and Arevo. Selective angiograms with more than 40 years of age, because if they can be associated with coronary disease, we need to send them for surgery. Here, standard hemodynamics need to be recorded. The widest portion of the neck of the aneurysm measured on the angiogram, though it is important, but most of our decision we would have taken on the echocardiogram, especially in the transesophageal echogram, what kind of a device, what size of the device, would have already taken a decision. The hardware selection, simple things are good enough. You don't need a very fancy things. Standard catheters like multi-purpose, jar catheters, regular thermowise, snares, you should have these. It's important to have all the sizes. The sheets, preferably I would prefer the braided sheets are preferable. Though if it is opening into the RA, the standard balloon sheath is quite good enough. Non-braided sheaths are good enough. Various types of devices, ADO1, 2, muscular VSDs, symmetric VSD occluder. I think it's not a procedure. It is not a particular device for this particular procedure. So this is two orthogonal views. You see that this is the opening into the RA. This particular case, I think we did as an emergency. This is an angiogram. So we don't see the TE probe there. It was nicely done. But we put a 1820 device. So that is the importance of having the two orthogonal ways, except in some straightforward cases. The defect is very easy to cross, I told you. And you cross, unlike a standard VSD closure, you snare it out, make a arteriovenous loop, like that. And the snaring out from the, which is opening into the RA and is very, very easy, and passing a sheath is extremely easy. Then put a device, and you have the pictile, and to know where to come out. I mean, in the initial phase, if you're not doing very frequently, this needs some time. You can spend some time on this short, about 5 cc or 6 cc, 10 cc contrast, and you can close this. 2 millimeter more than the measured diameter of the neck of the sac, because please remember this, most of these cases are adults. So we can just go at 2-3 millimeter, upsize the device and deliver through the balloon sheath. Most important, please remember the disc of the device released in the aorta. This is how it looks like. Ensure the position of the device, adequate distance from the coronaries. Please remember the initial stage that was, we were worried about coronaries are getting impinged. No, none of our cases we have had any problem with the coronary arteries. This is way distance from the coronary arteries. Confirm the aortic vegetation, no solution, then release the device. Retrograde approach, see, this comes to help. Some people might not like it, or some people may not approve this. So we can say we can everything, we can go from the antegrade approach. No, sometimes when this is opening into the RVOT, which a large aneurysmal sac tubular structure. So many times in elderly people, we may have some difficulty in entering the passing the sheaths, and also it's very easy to close. Put any kind of adult patients, you can put a 7F or 8F sheath easily. This is the wire is in the catheter, the sheath is in the PA. And you can have the another sheath for the, otherwise you can, most of the times nowadays with the echocardiogram, we can manage. We don't have to have the another femoral arterial access. Don't really need. This is all the initial about 8-10 years back, which was done. I just want to make a point that here we need to have the device which has got a double disc, like a muscular VSD or a ADO2. That is expensive. So CAG to ensure adequate distance from the coronaries, if in doubt, we have stopped doing this now because we know that in our experience it really doesn't matter. So this is another which was done from the antegrade to the ADO2. So here is a failed device. We have not been able to do opening into the RVOT. You see just below the pulmonary valve, it's a long redundant tissue. Whatever it is not even, maybe AVP would have worked, but we're scared to use the AVP because we don't know, because the thickness of the tissue is not much to hold the device. So that wanted to use a muscular VSD from both antegrade, we tried, we could not. So this is one case where we could not deploy. We did not get a good result. We sent for surgery. Few more cases. Very standard practice. Make sure that there is no ER. It's very important. Some residual shunt is okay, but if you can see, if you basically we need to buttress that aortic cusp, what we have done here, and some amount of intra-device shunt will be there, so nothing to worry about that. They will go away. So this is a very tiny rupture was there. Young lady, you see the rupture how it is dangling around between the RV and RA near the tricuspid valve. So in fact, when we did the pictile angiogram, the rupture and it became. So you are ready. So this is the standard approach we put it. So that is closed. Another recently done. This looks like a fairly complex one, opening into the RV outflow tract area. So when you have to close, which are opening into the RVOT, don't take the regular standard balloon sheets. Take always the braided sheets because it becomes easy to track our. You can preferably when it's an RVOT, preferably used to use the exhaustive wires. So this is a single coronary artery, which I just want to show you experience. The single coronary artery, very rare association. So monitoring of the patient, all patients on antiplatelets on 6 months. It varies whether being a dual antiplate or a single antiplate. The standard thing is a single antiplate. Sometimes we go an elderly patient, we have got dual antiplatelet agents. There is no fixed regimen. There is no proper guidelines for this, but antiplatelets are necessary. I think there are some incidents of sudden cardiac death. Dr. Bharat, I think, has some experience with that. I think he wanted to give oral anticoagulation. That is once again the individual policy. So as a policy, we don't give unless there is a huge sac. A lot of we are suspecting, we're anticipating some problem. In majority of the cases, we do not give anticoagulations. ECG rhythm disturbance, myocardial ischemia, watch for pulmonary edema in older patients. The moment you decrease the afterload here, we have found patients just under simple sedation. After a couple of hours, they all develop pulmonary edema. So just keep a watch on them. We may need to ventilate overnight in some of the people. Echocardiogram is extremely important to check the device position, residual leak, ER, appearance of new sites of rupture, it could happen. So this is how some of the cases, the echo pictures after the device deployment into the RA, you could see that device. So antegrade approach and retrograde, antegrade is a very standard one. The retrograde approach is very easy to do it, but issues that bulky design with the disc on the both sides, no need of people, that's a great advantage, very less fluoroscopic time. Bilateral femoral artery, you can avoid that. Retention skirt on both sides is necessary, more expensive. Bilateral may prevent multiple devices. It is, we have done about 5 cases, probably. So this is one study we published way back in 2015. But now we have more cases now in last 10 years. I think 10, 11 years, I can say we've done about 82 cases, age range between 11 to 79. Procedure success in 77. Referred to surgery during this period of 10 to 11 years, 16 cases we referred, including our attempted or some complicated cases where we have developed atrial fibrillations. So this is the, you could see here the slide, almost I can say 85 to 90% of the devices you can get away with the PDA device. That's good enough. Muscular VSD were used in A6, ADO2, just some residual shunts. I have put in 1 or 2 cases, more than one device. Then we have used this ADO2. Otherwise, primarily, ADO2 is not a device just. Maybe now with the Konar device, I think we can close with antegradely or retrogradely, either way, very, very easy to use. Some of these small to moderate size RSOVs. The correct technique, this is the one which you need to, I told you, the buttress the aortic cusp area. The incorrect placement, somewhere if you put the device in the sac, we're worried because there's a thin tissue. Not every tissue is same. So the key points is a good definition of the anatomy and both the transthoracic and the TE. 2 orthogonal projections are absolutely important many times unless we are very sure on the TE. Angiography and echo used to select size. Better to oversize by 2 mm. Margins of the wind sac are very flimsy. Avoid device in case of the excess unusable tissue. Or there is aortic prolapse or more than, these are all contraindications, which I already told you. Today's issues of the simple hardware are good enough. Watch for the complication. Don't hesitate for, to send them for surgery because if surgery is required, because it's not a very difficult surgery. Thank you very much.
Thanks, Jay, for sharing your really quite a wide experience of rupture sinus of Valsalva, and also giving us some tips, the technical tips of going about doing these cases, and more importantly, sticking to time. So I think we have a few questions for you. The first question is by Dr. Manish. Do you ever do balloon sizing of rupture sinus of Valsalva?
Never.
And do you think
there is no real need for it?
Okay,
there is
so
no
I think balloon
need for
sizing is not required, and most of the groups don't do balloon sizing. Now, when you do sizing of rupture sinus of Valsalva, where do you size it? At the aortic end or at the site of rupture?
No, at the aortic end.
At the aortic end, because as you showed in one of your slides, that to close the rupture sinus, you must close the aortic end and not the point of exit.
Yes.
For 2 reasons. One is the stability of the device, and second is even if the device is stable, if you close it downwards, you will not take care of the aneurysm, the aneurysmal sac.
Absolutely.
And which can be a potential for thrombus formation. So I think that is very clear that we should close the thing at the aortic end. One more question.
Can I?
Yeah, go ahead.
Can you hear me?
Yes, Radha, go ahead.
Yes, Dr. Radha.
That was a nice demonstration. You know, I was RSOV has always been considered as a surgical disease because you have this weakening of the wall, etc., etc. So one is always worried. Initially, the surgeons were very upset as to what we are doing. Trying to close this by a device. It's never going to last. It's going to further weaken the wall, etc., etc. So it has stood the test of time. And definitely now it is probably a class 1 indication if you actually ask me. Many years ago, I was very worried whether we are doing the right thing, whether we are weakening this weakening wall we have not addressed is actually we are just plugging a hole and we are not addressing the actual problem which is present in the aorta. So in our first about 20 cases, we did a CT after about a year and then showed that there is no further distortion of the aortic wall, so to speak, the so-called area of weakness. So probably this technology is there to stay for a long period of time because the initial worry was, are we doing the right thing? We are not addressing the main issue. We're just going ahead and plugging a hole, that's all. But then it seems to have stood the test of time. It's now probably more than 2 decades now since we first attempted. I remember Kelkar used to talk about it many, many years ago. And we presented this in the TCT. And we were quite happy at a 10-year follow-up. The wall weakness and all has not further progressed. The aneurysm has not further progressed. So I think it has stood the test of time.
I think Praful has a large series presented or published also in European Heart Journal,
yes.
some 30 odd patients. One more question for you, Jay, is from Dr. Lalit. As to the reason to close tiny defects, which I think you clarified that they would end up one day with a larger defect and hemodynamic compromise. Do I take it right?
Yes, yes. See, I can have my own personal experience here. One young guy, 27, 28-year-old, maybe 7, 8 years back. It was a very small, tiny, we did angiogram, very tiny rupture. We just left it. But exactly, please remember, believe me, that after 3 months, he came back with the symptoms, a lot of symptoms. What was the tiny became a moderate size. So I think even if it's a tiny one, I think we should close that because it's very unpredictable nature of the rupture of sinus of Valsalva. We can't predict which is going to increase, which is not going to increase. And it's a fairly simple, straightforward
surgical
procedure.
indications, Jay.
Yeah.
Every RSOV should be.
Yes. If there is a rupture of the sinus of Valsalva, need to be closed either surgically or with the intervention.
Indications are in the textbook also.
Nageswara, you had any question?
Small RSOV.
What is your threshold of aortic regurgitation? Do you send them for surgery if there is a trivial to mild AR, or would you prefer to close them transcatheter? Because our experience is bad. When we had a mild AR, we sent the child for surgery. Surgeons repaired the wall in spite that we told them because they found it was distorted. But the repair was not good and failed. And the second is large RSOV, vision vascular disorder. So we closed that. We actually took your opinion as well that. So I want you to comment on this regarding subsets.
So trivial AR, I think you could close it because most of this is distortion by fundamentally because of the anatomical issues. They may have a very trivial AR. That's quite acceptable to close it. But if there is already a baseline, if you have a mild AR, I think we should be worried unless it's an emergency. I think I would still, if there is a more than mild AR, I would probably send for surgery because a couple of them we have tried it. The mild, we are very worried. So, but those cases are very little.
And second thing is also Nageshwar, it is not very easy to estimate this AR because there is so much of runoff that many times once you take care of that runoff, what
the AR will reduce. AR will reduce.
Then becomes mild or more than mild AR.
Yeah.
But I think that unless the baseline AR is more than mild, then I think there is probably
no, it's a fairly reasonable. If it is less than mild, definitely
think we should consider doing a transcatheter closure.
Yes.
One other question for you was regarding unruptured sinus of Valsalva aneurysm from Dr. Sangeeta. Is there any role for transcatheter management in cases of unruptured sinus of Valsalva?
No, I mean, we don't see any clinical indication, but we need to close means we have to rupture it.
Would you like to put a device like a AVP2 or something and close the cycle? Because according to me,
no. That you should never do it. That you should never do it.
According to me, we should not close that because I have seen 2 cases of unruptured sinus presenting with a heart block.
Yeah. Actually, no, that is different. You have to send for surgery. You should never close with a device.
I think unruptured sinus of Valsalva, if it is significant, causing some AR, some RVO.
Yeah, this is surgery.
I think surgical approach would be a better approach.
Yeah.
Then there is one question. Any particular difference or precaution when doing an acute RSOV versus a stable RSOV?
Acute RSOV, I think fundamentally, if you think that an acute RSOV, a lot of hemodynamic, first and foremost is ventilate them. Give a general anesthesia, intubate them. Hello?
You can speak, we can hear you.
Yeah. You have to ventilate them. I think you are comfortable then. You prepare the hemodynamics within about half an hour of they reach your hospital and then take and then close it. I mean, once they intubate, you can put a TE probe also. I need to be fairly simple. You know, if you have the basic hardware ready already, it is fairly simple. But first and foremost, don't try to, we should not try to close these acute RSOVs without ventilation. That's what, because I think that's most, because invariably, even after you put them, you put a device, you finish the procedure, they will need a ventilation.
My question to you, Jay, is regarding estimation of VSD in presence of ruptured sinus of Valsalva. I find it very difficult when you have both the flow from the rupture and coming from the VSD to exactly estimate how big this VSD is, either on echo or on angio or on hemodynamics. So how do you make this? Because only when you close the hole, means the rupture, that you are able to estimate, oh, this VSD appears to be a little more than what I imagined it to be. So have you come across this kind of a problem because of the overlapping jets?
Yes. See, the 2 kinds of VSDs we have encountered in our series of 82. One is a subpulmonic VSD. When we make a diagnosis of a subpulmonic VSD, outlet septal VSD along with the RSOV, I think we have referred, though, even though I feel that subpulmonic VSD is very small, we have referred them for surgery. For other type of VSDs, we have encountered 2 cases, perimembranous VSDs. Even there, we try to underestimate the size of the VSDs in the presence of a RSOV because of a lot of factors, maybe because of the collapse of the aortic leaflet and all that. But what we have done in those cases, 2 cases, I have closed with a perimembranous simultaneously. I have closed with the device, both the RSOVs and a perimembranous VSDs. Close the RSOV, do the LV angiogram, assess the on both on angiogram and on the TE or echo, assess the VSD size and put a device. You're right. We try to underestimate the size of these VSDs in the presence of the RSOVs, especially the subpulmonic VSDs, which according to me, I think those cases, unless it is too tiny, even though I do not know whether it is call it as a too tiny, it might be slightly bigger than the what we see on the echo. So I think perimembranous VSDs can be closed if it is amenable for closure of the device.
No, most of the times the VSDs are moderate because of the cusp which is prolapsed.
Yes, cusp will be prolapsing and will be making you feel that it is a small VSD, which is not in fact.
This question is from Dr. Babar from Karachi. Do you put IABP prophylactically in acute RSOV ruptures with cardiogenic shock or severe heart failure?
No, not really necessary, Dr. Bharat. I think I have come across about 3 cases which I have done. I have come at night and I have done these cases. I told you the fundamental crux is the ventilate them and go quickly because the moment you close, the whole hemodynamics improves. The aortic pressure was 60, 70, it will go up to 120. That's, I think I have not put any ABP so far in any of these 3 or 4 cases which I have done as an emergency.
Can I have a point, Dr. Bharat?
Yes, please go ahead.
In any patient with acute aortic regurgitation or acute rupture of sinus of Valsalva aneurysm, occluding the aorta during the diastole is not a good idea.
Not a good idea, yes. I think, yeah. It's not needed really. It's not needed. You take care of the problem, fix the problem. I think the hemodynamics will be all right.
Sir, sorry to interrupt. We have one of the senior electrophysiologists of the country, Dr. T.R. Muralidharan is there. He want to ask a question. I'm unmuting him.
Please go ahead, Dr. Muralidharan.
Same like what Shiva said, IABP is contraindicated in this situation.
Contraindicated in aortic runoffs, yeah.
Yeah, the contraindicated IABP rather than the measure. Not even not advisable is not right, but absolutely contraindicated.
Jay, I have two questions for you.
Yeah.
One is regarding conduction disturbances.
Yeah.
I remember having read Praful's paper where they had, I think, 1 or 2 cases with AV block developing after closure of rupture sinus of Valsalva.
Yeah.
In your experience, have you come across any conduction disturbances, either transient or permanent, may not be immediately, but during follow-up?
No, Dr. Bharat, not a single one.
And my other question to you is regarding hemolysis. I have come across a case of hemolysis following successful closure, but because of the residual shunt. And as you know, because this is a high pressure shunt, there is a good chance of hemolysis. Can you tell us or share with us your experience, whether you had hemolysis, and if you had, what was the way of managing? Did you manage conservatively, or you had to go more radically to remove the device, go ahead with surgery? What did you do?
No, this happened with one case, the hemolysis. We knew that we had left a residual shunt because one more perforation. Initial part of the lecture, I told you that multiple holes are a rule in many of the cases. So, but that one particular case, I think we closed that residual shunt with a ADO2. So I think hemolysis subsided. This is only one case.
But you never had a problem of intra-deviceal hemolysis?
No.
Okay. As a matter of fact, we had, and we treated this patient conservatively. The patient
I think it'll work. It depends upon the type of the device. If you use a device like a cocoon device, I think the hemolysis is quite a common entity even in the VSDs we have come across. Otherwise, I don't think there's an issue, intra-device issue.
Okay. Because we had this intra-deviceal shunt in a physician, and it took us nearly 4 to 5 days of conservative treatment of diuresis, alkalization, and so proper.
I think it should help.
Take care. Any other comments or questions, either from the panelists or from the audience? Because I think most of the questions that came to me are almost done.
So I think today it's most appropriately timed, and there are no audiovisual disturbance, and the moderation is phenomenally great. I really appreciate and admire Bharat sir's moderation. And if everybody is okay, then we can close the session for the day. And tomorrow we are going to, Radha sir is waving. Anything, sir? Any question? Can you unmute Radha sir?
Yeah.
Sir, can you?
Yes, sir, you're unmuted now.
I'm just saying bye and thank you for the wonderful organization.
Thank you very much, sir.
Okay, thank you everybody. Thank you,
If it is okay with everybody, we would like to come back tomorrow, same time, same place, everybody at home with a new kind of video. And we are going to have a new international guest, Dr. Varakan from Bangkok tomorrow. So we'll have VSD session tomorrow. Thank you very much. Bye-bye. Take care. Stay safe and stay home.
Thank you.
Bye.
Thank you. So can I close the session, sir?
Yeah, please go ahead. Yeah. Today is the right time. I have never crossed my time throughout my lifetime except once or twice.